Hello, I'm Dr. Douglas Drevets, Douglas, Drevets, and I'm a professor of medicine at the OU College of Medicine and chief of infectious diseases at OU Health. I'll be talking today mostly about vaccine and vaccine efficacy.
Okay. Just start out with, tell us why, if you have an opportunity to get vaccinated, why should you do it?
So vaccination is important to prevent disease, and we know from the current vaccines that they can prevent about 90 to 95% of the diseases of COVID that's out there. And so by preventing disease, you keep people out of the hospital, you keep them from dying, you prevent a lot of problems. We also think that after you get vaccinated, you're less likely to transmit the disease to somebody else. Now this still needs to be proven because we're not yet sure if people who've been vaccinated can still become asymptomatically colonized with the virus. More than likely, many people will be able to prevent that asymptomatic colonization. And so if you have that, or if you have just a lot less virus in your nose and your throat, then you're less likely to spread it. So there are a lot of benefits to vaccination.
Okay. This is the question of the day. Pain relief medications before or after you vaccinate?
Right, so there is a theoretical possibility that if you take anti-inflammatory medications, such as ibuprofen or naproxen, before the vaccine, and you'd have to take it in sufficient amounts, that doing what they do, they dampen the immune response or inflammatory response. And when you do that, there is a possibility that you dampen the amount of antibody and cell-mediated immunity that is produced. There's at least a mouse study that suggests that with COVID. Now, on the other hand, this may not be a practical problem because the amount of immunity that you develop is going to be so great that if you reduce it by a small amount, it's not going to matter. The practical way to get around this is take the medicine after the vaccine and don't take it until you need it.
And since we're on the side effects topic, is that something that's pretty commonly needed after you get the COVID vaccine?
Right, about 80% of people will have a sore arm after having the COVID vaccine, and anywhere from 50 to 60% will have some kind of systemic symptom, such as a headache, chills, shivering, or muscle aches. And again, the practical way around this is if you develop those symptoms, you're welcome to take something for it. Medication such as acetaminophen is not an anti-inflammatory and will not do that. On the other hand, small amounts of ibuprofen or naproxen are probably fine, and indeed, all of those medications were allowed in the clinical trials.
Okay. So the state is not ready to move into phase 3 yet. They're still focusing on 65 plus. I think we have a really large population in Oklahoma of people over that age. So how important is it for that age group to be vaccinated?
So it's really important for the 65 and olders to get vaccinated because they make up about 80% or more of those individuals in the hospital and the deaths. So these are the folks that clearly at the highest risk for hospitalization and at death. And so that's why they need to get vaccinated. And that's why it's important to get through that group of individuals, which is indeed a large population in the state, before you move on to younger individuals.
Okay. How do you think the rollout has been going in Oklahoma?
So the rollout in Oklahoma has actually been quite good. We are among the top 10 states in terms of getting vaccine actually into arms as opposed to keeping it in freezers. And looking at the CDC's latest numbers from yesterday, I believe, about 60% of our vaccine doses have already been given. And my recollection is that puts us in about the top 10 of the states. So there have been hiccups. Some of the software is somewhat clunky and the registration system can be cumbersome. But overall, I think there's been real enthusiasm amongst many of the health systems to provide this service to their employees, patients, and to the community at large. And I think we've done really quite a good job.
When do you think we'll see another vaccine become get EAU. Is that what it's called?
So Johnson & Johnson reported their phase 3 results just this morning. And in that press release, they suggested that they're going to apply for emergency use authorization next month. So I'd anticipate that their vaccine will become available sometime towards the end of February.
Okay. Hold that thought. And kind of in response to your previous answer, do you think that with as fast as we're getting our vaccine administration going, that Oklahoma could become one of the first to obtain herd immunity?
So that's a good question about will we be among the first to obtain herd immunity? And the answer may well be yes, but that would be from a combination of factors, one of which is our vaccine distribution, the other of which is we've had an awful lot of COVID in the state for the last 2 months. We're among the top 5 in the country for the per capita COVID cases. So as that's racing ahead, we're adding to our numbers of immune people with vaccine. So yes, I think we will be ahead of many other states in terms of finding that magic number, the so-called herd immunity, where it's harder and harder for the virus to find somebody to infect, and then we'll start seeing the cases really drop significantly.
So back to the Johnson & Johnson's discussion, and that is supposed to be a single-dose vaccine, and it's right now touted at being around 66% effective against COVID. This reporter is saying, should I just wait my turn for Moderna or Pfizer since they are 95% effective?
Right, so now that a third vaccine may be coming online, now we have a choice. And you have to remember that it's not yet approved, is number one. And number two is, although it was roughly 66% effective overall, the study was done on 3 different continents. It was done in the US, it was done in South Africa, and it was done in Latin America. And each of those places had a bit different efficacy rate, with the highest in the US and the lowest in South Africa. And it was low in South Africa in part because of the variant that was there, and that and it just shows that the vaccine is not as good at preventing any disease. That said, among the entire trial, there were no deaths in any of the groups of those who received the vaccine as opposed to the placebo. So it does seem to be effective in preventing severe disease, even in the variants that were in South Africa, and it's highly effective at preventing death and hospitalization. So now it gets down to, should you wait until you get the Moderna, or should you go ahead and get the J&J? Well, first of all, I would wait until it's actually approved. We don't have an approved vaccine just yet. And then I would wait and see what the distribution to Oklahoma is, because again, even once it gets approved by the FDA for emergency use authorization, that doesn't mean that we're going to have the vaccine here in Oklahoma immediately. So my counsel would still be, I would get the vaccine, the first vaccine that you're able to get it the soonest. There will be some nuances as we see more data about the J&J vaccine. The only data that I've seen are from the press release. It suggests that it was incredibly safe and effective, again, in different ages as well, and different ethnicities. More to come on that.
So when you were talking about the South African strain, so that is that a deadlier strain, or is that just a faster spreading strain?
So the information right now suggests that the South African variant is somewhat like the UK variant in the sense that it's more contagious, but does not appear to be more deadly. That said, it has more mutations in it than does the UK variant, and therefore it is more different with regard to how your body handles it. And so as we can see from the vaccine trials, the vaccines are not without efficacy against it. They just don't have as good efficacy as against some of the other strains or variants.
Okay. But possibly keep you from getting it so severely. You may still get it, but maybe.
That's right. From what we know from the Johnson & Johnson trial, even in the South African individuals with the variant who did become infected none of them died. And so this is not unlike what we see with the flu vaccine, where it may not prevent infection, but it takes what may have been a severe case and turns it into a moderate case, moderately severe case, or a mild case. So there's still great benefit in getting a vaccine like that and having that type of a vaccine distributed in the community. Some of the stronger points of the Johnson & Johnson vaccine is that it has a much longer shelf half-life. It can be thawed and stay on the shelf at room temperature longer, and it's a single dose. And so it just becomes much more efficient to distribute and much more easy to distribute. Another interesting thing about the Johnson & Johnson vaccine is because it uses a different technology, the immunity that people develop increases over time, and indeed you saw more protection in individuals 6 and 7 weeks out from the vaccine than you saw at 3 and 4 weeks out. So it just keeps getting better over time.
Oh, that's interesting. And I wonder if, since the ones that are out now are the higher efficacy and they're going to the seniors and their 2 doses, I mean, that audience is probably more likely to follow up and do their second dose and just be more, and is in more need of it because they get the more severe response. Maybe it makes sense that the J&J would go to the younger audiences later. I don't know.
Could be.
Just me thinking out loud.
Yeah.
I wonder, let's see, this question is, I wonder if you have any thoughts so the legislative session is coming up, and that means large groups of people. What do you think about those kind of situations in terms of being possible super spreader events?
You know, anytime you get large groups of people, and sometimes even small groups of people together, you are going to statistically have people who are asymptomatically infected or pre-symptomatically infected. And so if you're going to get together, you really need to wear masks and socially distance and get your work done that way. It's very important to continue the same procedures that we've done because it is working. And we've seen that because we have very low influenza this year, low rates of influenza, and that is probably a manifestation of masking, socially distancing, and good hand washing that we've learned because of COVID.
Okay, that makes sense. All right, I know, and you'll probably want to say this on camera, that you don't see children, but I wonder if you have any insight to some situations that are being, on these next few questions that have to do with children. One of them is, somebody said that one of the reporters got an email from someone saying a 13-year-old girl developed type 1 diabetes after testing positive for COVID without symptoms, and her physician said that it was because of COVID. So that wouldn't necessarily just have to be for children, but just anybody getting sick.
Right, so the question has to do with how does COVID trigger other problems in the body? And there's an anecdote of a 13-year-old child who developed diabetes after asymptomatic COVID infection. And her physician stated or told them allegedly that it was because of the COVID. So with the caveat that I do not see children in my practice, and I'm not a trained pediatrician or trained pediatric infectious diseases specialist, a few comments on that. First of all, I would wonder how the physician knew that was indeed triggered by COVID. You know, I think that could be a stretch to say. Secondly is the idea that, you know, within a population, certain events are going to happen. And certain health events are going to happen in any population after something else happens. You could say, well, you know, after the Super Bowl, there are going to be X number of heart attacks, you know, in the 12 hours after the Super Bowl ends. And is that because a particular team wins or loses? Well, it's hard to say, or it's hard to draw a strict conclusion. And so it's an attempt at, or an example of what's called post hoc thinking, or something happened afterwards, therefore it happened because. So it's just hard to make that connection right there. Is it possible? I suppose it is in theory possible, but you would have to do a lot of work epidemiologically to show that in a relatively large population of adolescents or individuals, that after COVID, there were higher incidence rates of type 1 diabetes in the community. And then you'd have to provide some kind of a molecular link or, to make that plausible. So
The things that would be more obvious and logical or easier to explain would be long-term symptoms, that maybe you have long-term lung problems or things like that that were caused because of the disease, what the disease did to you, right?
So it is very clear, at least in adults, that if you were hospitalized with COVID, about 60% of adults are going to have some kind of persistent symptoms 2 months out. And for less severely infected individuals, those who had symptomatic COVID but who weren't sick enough to go into the hospital, about a third of those individuals will have some kind of persisting symptom 2 months out. And so we're beginning to study those. And, again, persistent symptoms after severe infection is not something new. And they do also tend to linger after severe influenza and other viral diseases such as Ebola. You can have persisting symptoms or manifestations for months.
Okay, since you do not see children, we're not going to really go into these other questions. I think about kids, but this one's interesting. This one says, we are now encouraged, and I'm not sure where that's coming from because I don't think the CDC has recommended it, to wear 2 masks due to the new strains. Do local doctors believe they are already spreading in Oklahoma? Do you think the strains are already spreading? And then do you think the 2-mask system is a good idea?
So the question has to do with, are the new variants spreading in Oklahoma, and do we need to wear 2 masks because of them? Well, first of all, I think it's pretty clear that the new variants are already in the United States, and so it's a pretty safe bet that they will get to Oklahoma, at some point in time if they're not already here. Hopefully we will know that through sequencing of isolates, and I don't know if our new testing facility in Stillwater is going to be sequencing these isolates, but it would be a good idea and very informative to perform sequencing of local isolates so we would know that sort of information. I don't see a particular reason why 2 masks would be better than 1 unless your one mask, your first mask is a 1-ply bandana. If you have a good surgical mask or a good N95 and you wear it properly, that should be sufficient. My recollection is that the Centers for Disease Control has not changed their recommendations for masking yet. And so it all gets down to how good is your first mask. If it's a very thin piece of cloth, well then it's probably not very effective and you do need to do something different, but it's not because of the variants, it's because you have an ineffective mask. And it's always important to know that you have to have your mouth and nose covered. So if you need 2 masks, 1 for your mouth, 1 for your nose, well then I guess that would work.
So you have, being in infectious diseases, you've studied infectious diseases throughout your education, your career, and was it having new variants? That is not something that would be unexpected. We would assume that does that happen pretty often with?
It happens all the time with viral infections. And, viruses, particularly RNA viruses, like COVID or like influenza, they are designed to mutate. And so this is a standard thing that happens, and they mutate against selective pressure. And the pressure, in this case, is more than likely provided by your immune response. Sometimes the selective pressure is provided by antiviral therapy. And a fair number of years ago, we saw how a drug called amantadine or amantadine, which had been a mainstay for anti-influenza, just in 1 year became completely ineffective because a mutant strain or a strain of influenza that was mutated and not resistant to it just took over. And so these things happen all the time. We see it in HIV. It's essentially de rigueur when you're dealing with microbes and particularly viruses.
Okay, this might be really stupid, but say you get herd immunity everywhere, and so does the virus, does it just die? Does it just sit there dormant till 20 years from now? I mean, what happens?
So that's a good question, and the question is, so after you get serious herd immunity in a population and the viral viral infections seem to drop off and go away. What happens to it? More than likely what will happen to this one is it will circulate still at some level like the other seasonal coronaviruses that we have. And there are 4 seasonal coronaviruses that cause common cold. Over time, they often become what we call attenuated or less virulent in terms of they cause less severe disease, but they're more easily spread around. And from the virus's standpoint, that's a good thing for them because they don't necessarily want to make their host sick. They just want a place to live for a while, and they want to be spread easily. And so more than likely, it will fade into the background and become part of our seasonal cold.
I don't have any more questions. Anything you want to add?
No.